Hello, I'm Susan Cole from Phoenix Health Movement.
And I'm Denis Onyango from Africa Advocacy Foundation.
And welcome to episode 6 of Positive Health, the broadcast series focused on HIV and the pressing issues affecting Black communities. We're joined by two absolutely amazing guests in this episode. First of all, we have Dr. Michael Brady, who is an HIV and sexual health consultant at King's College Hospital and the National Advisor for LGBT plus health at NHS England. He was previously the medical director at Terence Higgins Trust, where he helped drive improvements in HIV testing, including self-testing, provision of PrEP, and sharing the U equals U and can't pass it on message with people living with HIV, at risk of HIV, and healthcare professionals. He has a particular interest in HIV transmission and prevention, HIV testing and PrEP, and addressing inequalities for marginalized and underserved communities.
Oh, and we have Ophelia Haanyama, who is a long-time activist, speaker, and author who was born in Zambia, but based in Sweden since 1991. Ophelia has worked over 3 decades and has been part of many initiatives and networks, including a program called Women for Positive Action, and also being involved with AIDS Action Europe. She has been a pioneer when it comes to implementing community initiatives, such as community testing in Sweden. She holds a passion for reaching out to migrant communities, and as a woman living with HIV since the early 90s and a mother of 2, she has also worked with parenting, menopause, and ending HIV stigma. Ophelia has written 2 books. One of them is Ophelia's Journey, and the other one is called The Journey Ahead, Ending the HIV Epidemic. And she's my very, very good friend and very inspiring. I'm always in awe of her, so really glad to have Ophelia here.
Yeah. She is absolutely fantastic, and Michael is absolutely brilliant, and I've been a fan for many years. So we've got 2 fantastic guests. I know that lots of people working in the HIV sector are going to be really busy over the next couple of weeks because we're very close to World AIDS Day, and World AIDS Day is a really important time for us to reflect on the people that we've lost and celebrate the progress that we've made. However, people from Black communities continue to be left behind. We're more likely to be diagnosed late. We face barriers to testing, staying engaged with care. We have worse health outcomes, and so many of these disparities have gone on for many years with very little progress. But I think that there has been some significant changes recently. I think the fact that we are now having conversations about the impact of racism on our health is really important, but also I think there's now more recognition of the importance of Black communities in leading within the HIV response, not in that tokenistic way that we've seen for many years, but actual true leadership. And that's something that we've seen with many of the amazing guests that we've had on the show, not just highlighting, these are the problems in HIV, but actually posing lots of really important solutions. And I'd like to give a particular shout out to one of the guests that we had last week, Husseina Hamza from Red Ribbon Living Well, who has recently won a health equity award at the Health Service Journal. So true testament to the crucial leadership of people working in HIV from Black communities.
Yeah, absolutely, Susan. I think that for us, World AIDS Day is a celebration of people doing this kind of work every day, and not just one date on the calendar, as you know. So I think that we need to pay tribute to community organizations, the peer advisors, the advocates, the activists, who are working on the ground every day to make sure that we address the gaps that we see in HIV prevention. But also, I think it's a day to remind ourselves that that we have the tools to end HIV. And we have PrEP, we have equals to you, we have excellent testing and treatment. And I think we shouldn't be having the inequalities that we see. So I do think that this day is a very, very important day to remind us not only of those we have lost, the families and friends we've lost, but also the fact that there is still massive inequalities and there is need for us to be able to speak louder and to pay tribute to the amazing work that's being done. As Mark Lewis actually wrote 3 weeks ago, a very brilliant piece on LinkedIn, where he was saying that community organizations need to be supported and funded to continue with the HIV, the fight against HIV.
Absolutely, I couldn't agree more. And I think one of the ways that we're also really benefiting is through the partnership with really extraordinary healthcare professionals. And luckily we have one now. Let's bring on Michael.
Hi. Hi, Susan. Hi,
Hello,
Denis.
Michael. Hi, Michael. Thank you so much for coming on the show.
It's a pleasure, as always.
Wonderful. Michael, people from Black communities are more likely to face barriers to staying engaged in HIV care. From your experience of working in a London HIV clinic, what's driving this and what's actually helping to get people back into care?
Yeah, I mean, I think as you highlighted earlier in your introduction, supporting people to engage in care long-term for lifelong care, it is really challenging for a number of different communities and sometimes particularly for Black communities. Where I work in South London, colleagues have been doing a lot of work in recent years, trying to understand the reasons why people struggle to engage in care, why and what we need to do to support them to come back. And as you've highlighted, the world of HIV nowadays is so different than it was even just a few years ago, and certainly in the early days of the epidemics. We have such amazing treatments where most people are taking one tablet once a day, no side effects, completely well, living long, normal, healthy lives, and can be 100% confident that they will not transmit the virus to their partners. But even with those very strong messages, it is still sometimes a real struggle for some people to engage in care. There are lots of different reasons for that. It can be related to other life pressures, to poverty, to unstable housing, to just having kids and life and money struggles, mental health problems, drug and alcohol problems. But I would say that probably, and I'm sure we're going to talk about this some more later, the single biggest thing is HIV stigma. It underpins everything, and the stigmatizing approaches still in society and how individuals can sometimes stigmatize themselves means that they struggle to come into care. And we know actually now that there are more people living with HIV in this country who know about their diagnosis but are not accessing good healthcare than there are who are undiagnosed with HIV. It's estimated to be maybe between 5 and 10,000, so between 5 and 15,000 people. So our recent work has been to really kind of refocus a lot of our efforts, not to stop testing and not to stop focusing on treatment, but to really to think about what are the reasons why people struggle to come into care and how can we support them. And there are a number of things, but they often involve social support as much as medical treatments. And you mentioned the important role of voluntary sector organisations and the really important role of peer counsellors and peer support. I would certainly say that is probably the single, it's a multifactorial approach, but probably the single biggest thing that makes a difference, certainly in the clinic that I work in, is the work that peer support workers, so people living with HIV who are experts by lived experience, who can connect with people sometimes a lot better than we can as doctors and nurses.
Amazing. Amazing. I mean, Mark, it's quite interesting the point you've raised there around people who know their diagnosis but are not accessing care being more than people who are undiagnosed. It's quite very interesting information. I really think, thank you for that insight. I just wanted to ask, so we know that Black people are disproportionately when it comes to late diagnosis, and I was wondering whether you, as a clinician, has any suggestions on what the approaches we could use to make sure that people are effectively reached with HIV testing on time.
Yeah, I think of all the people, of all the Black people diagnosed with HIV last year, half of them were diagnosed late. And late diagnosis has a really significant impact. It means that somebody hasn't been able to access treatment at an early stage. It means they're at greater risk of getting ill or even dying. And it means that they have an ongoing risk potentially of transmitting the virus to their partners because they don't benefit from treatment, and U equals you. I mean, I think there are similar reasons why people, particularly Black and minority ethnic communities, don't engage with testing, as to why they often sometimes struggle with engaging with care after that. A lot of it is about stigma. A lot of it is about fear. A lot of it is about, I think, perhaps people not feeling that they're potentially at risk from HIV. It's got that sense of it's other people who get HIV. It's not me, or it's not people like me or people like my family. The fear of the diagnosis, perhaps not understanding that it's a completely treatable disease, that they can live long, healthy lives, have families, have babies, have new partners, sexual partners, don't transmit the virus. So I think there's still a lot of people who see it like the disease it was in the 80s and 90s and don't understand how different it is now. I think also sometimes the system doesn't help. A lot of HIV testing happens in sexual health services. For a lot of people, it's not acceptable to go to sexual health services. It's not a common thing. It's not a particularly nice thing. It's not a very convenient thing. You may not have one that lives nearby you. You might have to queue to get in. You might get turned away. They're very busy. So we in the NHS sometimes put too many barriers up against against people testing. So I think that's why initiatives around testing, like self-testing for HIV, where you can now just go online, not everywhere in the country, but you can now just go online and just order a kit, do a finger prick, get the result yourself, like doing and reading a pregnancy test. So super simple, don't have to go to a clinic, super confidential, no shame, no embarrassment. And then obviously if it's a reactive result, we can wrap you up and take you into the services and give you all the support you need. And also self-sampling, similarly, where you order a test online, do it yourself and post it off. So I think there's a lot that the system needs to do to make sure that those new testing initiatives are available to all communities, in both rural and urban settings, probably even more so in rural settings, because you're less likely to be nearby you then.
Absolutely. Thank you so much, Michael. And it's so important that everyone has the opportunity to benefit from the progress that we've seen. And we know that PrEP's been an absolute game changer, but Black communities seem to being left behind. What changes would you like to see with regards to PrEP, so Black communities are more likely to be able to access it and also feel empowered to use it?
Yeah, you're right. I mean, PrEP is an amazing advancement. A tablet that you can take that gives you near 100% protection against acquiring HIV. But like everything else, Black communities are much less likely to know about it, to think that it's for them, to feel comfortable accessing it. Again, it's only available in a sexual health service, so those barriers, similar to testing, are a real challenge. So, and we've had really effective tablet PrEPs for ages, and now we're just beginning to roll out injectable PrEP, which you can have every 2 months, so you don't need to keep tablets at home, and that, I think, will be a really big change, particularly for Black communities and other marginalized and underserved communities, because it removes some of those barriers. If you don't feel comfortable having the tablets at home, if you have any other problems taking the tablets, then coming to a clinic every 2 months to get an injection may well be the solution. So I think we need to make sure that everybody who would benefit from PrEP knows about it, and that we don't do enough. People need to know it's not just for gay men, it's for everybody who might have a risk of HIV. It's very simple, it's very safe, and it's very effective, and we need to raising awareness and letting people know about it. And I think that's not just at communities like Black communities who need to know more about it, but it's also healthcare professionals. There's a lot of people who don't work in sexual health and HIV who don't know enough about it and aren't talking to their patients about it. And we need to make it available in a lot more places than it is. It's a significant barrier that you have to come to a sexual health service to get it. So pharmacies, potentially GP practices, and there are a few online PrEP services which have started, not nearly enough of them. There's one in East London, certainly there's one in South London where I work, but they need to be everywhere, because that would definitely make access easier.
Thanks, Mike. I mean, that's really important because obviously we've been discussing about, the advancement we're having in HIV, but also the fear that we may not be able to, I mean, some people are not able to access this technology, however good it is. I think, there is need, especially for advocacy in all corners, but also I think trying to make sure that we create awareness so that people know that these options are available and that, they can access them. But I wanted to raise the issue of, disparities, especially amongst Black, gay, and bisexual men as a key population. We know that they're experiencing inequalities in sexual health, and I wanted to know from you if you have any advice for us on any advice you'd give someone from this community who feels that the care is not addressing their needs. So what would they do from this community?
Yeah, I mean, we've talked about inequalities and marginalized communities when we've talked about Black communities, but there's a concept of what we call intersectionality that makes you even more marginalized or even more disadvantaged. And that's when you've got more than one minority characteristic, if you like. So gay men are a minority community, but gay men from the black community are another. And we know that when you have more than one of those sort of marginalized characteristics, your inequalities are greater, whether that's Black, gay, LGBT people, or younger ones or older ones, or people with disabilities. So I think there is something, I would say there's something for us in the system that need to do more rather than putting the onus on those individuals. And I would go back to some things that you were saying at the beginning, Denis, which is about voluntary sector organizations, community organizations, because I think they're much closer to people like this, or put much closer to marginalized communities than we in the NHS are, understand their needs better, and probably have greater confidence and trust in those organizations. And the history of HIV is really about activism and community and grassroots driving change, and that's no different for Black communities as it is for gay and other minority communities. So I think we as a system need to support voluntary sector organizations better. It's a very fragile community. Money is very difficult. It's very hand to mouth. You're laughing here. I don't need to tell you that, but it's so important. And I think the NHS doesn't recognize it enough as a resource, and a really essential resource, particularly when we're talking about marginalized communities like Black and minority ethnic LGBT plus people. So I think I think it's the system that needs to do more working with voluntary sector organizations. But I think, as you said, and your question was, what would I say to an individual from that community? If there is a local community organization, find it, because they will be the best way to address whatever issues that you have. And hopefully we'll be working with the NHS as well, because that's how we provide the best wraparound holistic care.
Wonderful. Thank you so much, Michael, for coming on.
It's a pleasure. Thanks for having me.
Conversation.
Thank you. Bye.
Bye.
Thank you.
Wonderful. And Michael raised so many really important points, particularly around the issue of intersectionality. And we know for women that we face intersecting forms of stigma, discrimination, and disadvantage. And that comes to HIV prevention. And Denis, you've been doing some research on women and HIV prevention. Have you got some insights that you can share with us?
Oh yeah, so as part of my Health HIV partnership that we do in Europe, we had this initiative which was funded by that was looking at PrEP amongst migrant women. So we looked at many things like, their gender, their migration status, ethnicity, sexual orientation, PrEP usage, but also we looked at, the other intersecting factors like, whether they have a history of or current or history of domestic abuse, their living situation, and obviously, whether they have kids. And we found, we surveyed around 521 women, 78% of these were aware of the HIV status, but only 13% were. So we're actually looking at various prevention methods, and only 13% were using PrEP. We were having, 55% of these had children, and around 18% had engaged in transactional sex because of the difficulties of living as a migrant. So very, very telling figures there. But the fundamental issue is that prevention was not meeting the needs of women. In that for a lot of women, the prevention method they preferred was not available to them. And I think that's something that we really need to look at seriously because of some of those intersectionalities around status, gender, domestic abuse, and just inability to be able to access services, and the barriers, the legal barriers in Europe around who can access and who cannot access services. So I think that's really, really important to look at.
Yeah, no, absolutely. It is so important that we look at all of these issues, but I also think messaging is also crucially important, and how we discuss HIV prevention. And I'm really pleased to be involved in a new campaign, Risks to Reasons, about women and HIV prevention. And it's very much reframing how we have those conversations, moving away from talking about the risks of HIV, and so often that comes fueled by stigma and shame and anxiety, and reframing it to much more empowering conversations about the reasons that women should be engaging in HIV prevention, and actually finding the type of HIV prevention that's right for them, so women can be so much more empowered to make informed decisions. So I really think that we need to shift the mindset with regards to
the narrative as well. Yeah, it's a change.
Absolutely. And a segue to the fact that we have a women leader in the HIV response as one of our guests. Let's bring on Ophelia.
Hi, how are you?
Oh.
Hi, Ophelia. It's absolutely wonderful that you can join us today. And so, Ophelia, you organised the absolutely groundbreaking pre-conference at the IAS conference, Women Know What Work. I was really pleased to be one of the presenters at the conference, and I know that you're going to be organising something in Brazil, fingers crossed, for next year. So at the AIDS conference, what are some of the actions you'd like to see to improve the health and well-being of women living with HIV?
I think we start from why I put that together, Women Know What Works. So I went back to the time when HIV was actually, I'm from Zambia, when actually people were dying. The persons that were taking care of dying people, whether they were men, women, it was women. They knew what to do when the health system was not there. They lost their jobs. They were taking care of their families. So I also realized after going to so many conferences in the world, there was nothing that was actually taught about what women do on a platform where there are a lot of actors. So we also, as much as we're saying what we don't have, it is nice to actually explain what women have done so far for 40 years. That is maybe documented or undocumented, because we, as women, we don't have time. We are caregivers. We are taking, we sort of are so busy that we don't have time to think, because time is a luxury. As much as you don't understand, to have time and to get bored is a luxury. Most women don't have time to be bored, especially migrant women. I came here as a young woman. I have 2 children. My day started with breakfast, taking my children to school, going to find a cleaning job because I didn't speak Swedish. So for me to read, I maybe had 30 minutes in the evening when I was very tired. So I couldn't be innovative, not because I'm stupid. I didn't have time to be innovative. So we have to look at what has been done that women have done, and then empower women in whatever level they're at. We are not asking for everyone to be like me. I'm not asking for everyone to go out and speak loud. That's what I'm asking for. In whatever space you find yourself as a woman, also find a space for development. Also find a space to ownership. And you can have only ownership if you acknowledge your position. The first change square is when you know, where am I? Who am I? In this context where I find myself in. I find myself in the context of Sweden, where the language is very difficult to learn. I'm a Southern African woman living with HIV with 2 children and 2 grandchildren. That is my reality. So from that reality, How do I have time to express my capacity, not negative, what I'm capable of doing? If I raise 2 children by myself, I'm capable of changing something in the world. That is the thing that women generally don't talk about. We don't come together and look at what is the area of focus. Since we're in Europe, most of the women living with HIV are not from Europe, not Western Europe at least. So they came here as migrants, or they were born here from migrant parents. How much tools do we have to express our choices, our decisions, our development? The little time you have, the less developed you can be, and the less articulate you become. So I feel that we can all do this together, and no one can do anything by themselves. If you want to walk fast in any development, walk alone. But you won't walk far. But if you want to walk far, build a collaboration of people that complement you. Even if you have to learn from women, even if you have to learn from men who have sex with men, we can do it. Together we can. And living with HIV for 40 years, I've maybe learned a lot. I've made my mistakes. But one thing I've learned is that women are much more stronger than anyone gives them the credit for. And I hope I hope women know what works will be movement, not only in HIV, in any environment you find yourself in, whether it's business, whether it's work, whether it's motherhood. Usually we have raised all the people in the world as women.
Fantastic.
Amazing, Ophelia. Your work reaches many migrants with diverse migration statuses, and from undocumented migrants to diplomats. I wanted to know how you tailor your work to meet the various needs of migrants, whether they're living with HIV. And specifically, if you could also refer to your testing work in Sweden, what you think might be done to improve testing throughout Europe, basing on your experience from Sweden.
I think what we need to do, migrants come here for different reasons. Some come here because they marry Swedish people, marry European, they come to study, they are diplomats. You have to meet people where they are. You have to adapt to their culture so they can take the messages properly. You cannot go and do a European Christmas at a Nigerian party. You have to meet people and address and respect their cultures. That is what we do. We go out on African festivals, we go on national days, we go on African Day, and every place we go, we have mobile testing that people can, whether they test or not, we are just saying it's a simple test and we'll link you to care.
Yes.
Just be where the people are. That's as simple as.
Fantastic.
Yeah, that's so important that we are where the people actually are. But for many women living with HIV, as you mentioned, so often regularly juggling so many different responsibilities, there's so many really negative things happening in the world at the moment. What advice would you give to a woman living with HIV to actually how they could take better care of themselves?
Own your status. Own it. You can only find a solution to something that is yours. You cannot find a solution if it's not your fault. You own your situation, you own your status. It's hard. Once you have ownership, you find solutions. And you can do that by yourself. With support, maybe peer support, but ownership is the first thing. Even for seeking support, you have to have ownership.
Mm-hmm. Yeah, I agree. Peer support is so important as well.
Exactly. Yeah.
Yeah, I'm Ophelia, just of course reflecting on work that you've been doing again in Sweden, but also collaboration across Europe. What do you think are the most urgent needs that need to be looked at, especially in trying to address inequalities we see in HIV?
Is addressing the issues that are actually important to people. Don't fantasize things, just be real. Just deal with what is there. Deal with what you see. Don't complicate it. It's what you see is what you get. And also stigma is the biggest. It doesn't matter how much medication we have. Stigma is what we need to sort out. And we may be part of creating it as media, and we need to sort it out as media.
Absolutely. And for lots of people, it's self-stigma that's a really big issue. What do you think can help with that?
Because you don't have to have everyone accept you. Self-stigma is expectations. When you expect people to like you, you're going to get upset when they say no. We should be ready for someone saying, I don't want to see you because you are living with HIV. It's fine. I don't want to date you because you're Black. It's fine. There is a no to everything you do. It's expectations lowered, expectation managed.
Wonderful.
Fantastic.
That's so important. And thank you so much, Ophelia, for coming on. You're such an inspiration to me and for so many people all around the world. The work you do is absolutely fantastic.
Thank you. Thank you so much for having me.
Thank you.
Ophelia. Yeah.
Like that.
But,
Yep.
oh my goodness. Oh wow. Like what two absolutely inspirational speakers we have there. And unfortunately, that's all the time that we have. I'd like to thank all of the audience for joining us today.
Yeah, thank you, Mike and Ophelia, for coming on the show. You are great.
And I'd like to thank Disruptive Live for their technical wizardry in making this all happen. And I'd like to let everyone know that this is actually our last episode for 2025, but we will be back next year. So please let us know what you've thought about Positive Health broadcast so far, and let us know if there are any topics that you'd like us to be discussing next. When we're back, please do like and subscribe on our YouTube channel. And I'd like to thank also all of the guests that we've had so far on the show. Everyone's been absolutely amazing. I'd like to give also a shout out to Angelina Namiba, who was one of these guests who gave me this necklace.
What a beautiful necklace.
For my birthday. And I'd like to thank you, Denis. Oh my goodness, I've loved doing this with you. Same
here, Susan. You've always navigated me through this. It was not a strong feel, but I've learned a lot, and I'm so grateful for the opportunity to do this with you. It's been wonderful. And I've learned so much from you, Denis. So thank you all, everyone. Have a wonderful World AIDS Day, and we will see you next year. Thanks very much. Bye-bye. Bye. Thank you. Bye. Bye. Merry Christmas, everyone. Merry Christmas.